Дайте лако. So, dear colleagues, this is a case of a complication, a complex case after Cerab. This technique of covered endovascular reconstruction of aortic bifurcation, which is done at Lery syndrome, and one of the complications is dislocation and pseudoaneurysm of iliac artery. So this is a patient with three hospitalizations at our hospital. The first hospitalization was after he was diagnosed with Lery syndrome, and we performed stenting of the aorta and the iliac arteries. The second one was because of puncture site complication with thrombosis, and the third one, and the most interesting one for me, is the pseudoaneurysm with the dislocation of the iliac stents that we implanted in the first hospitalization. So this is the first hospitalization. Patient came with symptoms of claudication and pain at short walk distance. He had already wound of the second finger of the right lower rim. From the status, you can appreciate that there is a pathological ankle breaking index, which Docent Nikolov already mentioned, and he had absence of pulse of the common femoral artery in both sides. So we performed the CT angio, and from the CT angio, you can see that there is occlusion of the aorta, infrarenal, and at the level of the two iliac arteries, and both common femoral arteries are occluded. That's a classical Lery syndrome. So what we did was a hybrid treatment. We did endarterectomy with patchplasty of the common femoral artery, of the left common femoral artery with synthetic patch. After that, we punctured the graft, and we put the 40 French introducer to finish the procedure. We did Cerab with cover stent into the aorta, and two cover stent with two self-expandable stent into the both iliac arteries. So можете пустите видео. Не, назад. И що е то? Не е ли там е било окей, де съм качил презентация? Като съм качил презентация е било окей, у първа сала. Не, у първа сала е било окей. Houdini case. Па да ставим мой компютър. Дали там е кренуло? Не, само презентация. Да. Там е кренуло. Я може да ставим мой компютър.
Да отворим.
Да. Да. So, Professor Vasilev, we're in the peripheral session, and one coronary case became a peripheral one. We are watching with very high interest. Can you explain us what you have done until now for the audience, because there are colleagues that they are not doing peripheral?
The case became exactly the topic of your session. Just maybe the colleagues know, this is the result from the after report of the AAG.
Kako je išlo tamo?
Bio je u folderu je video.
Ne, nije folder. Samo prezentacija.
Here we have to switch to left femoral. This is the left jockey catheter which I analyzed the left iliac artery. Then I placed a wire into the left femoral artery and I punctured the left femoral artery just to be 100% sure that my puncture is exactly the place, and as you can appreciate, we have just at the top of the femoral artery, the bone, the femoral bone. So then I checked this one and I switched, I canalized my left Judkins catheter from below.
Sredili su.
And with a guide wire, then I switched to the left and I replaced over the guide wire. I placed right Judkins diagnostic catheter in the right femoral artery. This is the angiography from the right femoral sheath. You can see that there is a normal flow of the femoral artery. However, there is a significant fibroid dissection at the level of puncture. Here you can see clearly this dissection. I was wondering how to approach that because all the time the wires were going into the false lumen up to this dissection. And then I switch now. I left the wide wire into the dissection plane and I took a coronary wire. This is the regular run-through wire, which crossed the dissection, and my wire is femoral artery. So now, because there is no any support from this wire, we'll take Navicross catheter. We'll take the Navicross catheter and I will place the Navicross catheter over the coronary wire. Then in the meantime I switched the diagnostic right Judkins catheter. I switched it for the right guiding catheter 6 French. The wire into the right femoral sheath was left just to secure the access. And now the plan is just to place another cross catheter across the dissection, then to place long 35 wire there, and then we will place a battery stent just to fix this problem and to finish the case. As you can see, there is no problem, but my wire went somewhere in the nowhere. why not to leave this in this way. The problem is that when we have to remove the sheet, and this is a significant size sheet, this is a 7 French sheet from the femoral, and to compress this dissection there is a significant chance of thrombosis of femoral artery and to appear with acute lymphemia. And I don't want to go into this situation with this patient. So this is why I have to resolve this in the most secure way. Maybe I will see, maybe we will place a further device on the left femoral.
Dobry, can you hear me?
Yes, sure, Miro. How are you?
Fine, thank you. I'm in Serbia, so I'm fine. So I have a proposition for you. If you do not want to put a stent, we did this yesterday. We put a balloon and remove your sheet from the right side, and to compress, not to compress, but to use the balloon as a occlusion for your hole in the from contralateral side. A long inflation, for example, with 6 or 7 millimeter balloon at the puncture point.
Okay, so I don't have any hesitation about my glass stent because the patient, as I said, had дайте ми едно петли шестица, ако обичате до 58. Because my patient is paralyzed on the right side, so she didn't flex her right leg. And I don't want to spend half an hour pressing, deflating, inflating, and so on. So I would like to finish this case in early Saturday afternoon as fast as possible.
Yeah, that's the fastest way. Yeah.
And can you tell us what is the distal location of the stent? Where you're gonna place it? You're gonna place it at a border with a common femoral? Because you have a long sheet, I believe, in the right femoral, and there's gonna be.
normal sheet.
Regular sheet per centimeters. It is not a long sheet. I will inject the contrast just in a few minutes.
Because I don't see the length of the dissection. Is it going distally from the sheet or not?
It is exactly the bifurcation with the deep femoral artery, between the bifurcation of the superficial and deep femoral artery, so I had to cover the ostium of the ethnic contrast. I have to cover the deep femoral arteries, unfortunately, despite it is not... Миличка, отнеси ръчичката оттам. It is not so big vessel. Yes, maybe we will be lucky, and I will try not to cover it.
Yeah, I think you have space.
Clearly seeing that probably it will be possible, probably. Okay, so we'll make one more injection, and then
If IVUS is available in a cath lab, can you do a IVUS run for this segment? Maybe you will understand what is the length of the dissection.
I think that we already understand it by intuition.
Maybe just to close the mouth of the
dissection and it will close
Yeah,
itself down.
it's easier because he doesn't have to pull the second introduce sheet.
4, 5, 6, 7, 8, 9, 10. Okay. Have a good puncture site closure. So, have to wait. One of the important things in this situation is just to wait, not to fast to deflate the stent, just to wait and just to see what is the situation. We don't have any bleeding on outside. So I will wait for 1 minute, we will deflate the balloon and then we will make an angio. So,
Neno,
yes, sure.
prezentacija. Prezentacija tako.
If you want, you can continue with the presentation, and after the next presentation, we can
Okay. Okay, thank you. Thank you. Can you put the presentation, please?
So, I'm going to return. So, as after the procedures, the hybrid procedures, this was before. You can see that the CT angio and the angio into the cath lab is the same. So after the procedures and the implantation of the stents, so the patient was discharged, but after a few days he came for the second time with the pain in his left lower limb, where the procedure was done with temperature asymmetry of the two legs and inflammatory process in the area of the left operative axis. So back then we did surgical treatments. The vascular surgeon did the revision of the left reconstruction, thrombectomy through the patch with removal of the thrombotic masses and the restoration of the blood flow to the reconstruction. They refreshed the edges of the surgical wound and we did the antibiotics. The patient was discharged with improved vascular status, available blood flow into the reconstruction, no thermal asymmetry, with refreshed operative access and with no complaints. But a few weeks later, he came for the third time and his complaints were about the pain in the left lower limb and to the abdomen. From the status, there was a pulsating mass into the left inguinal region, and on the Doppler sonography, pseudoaneurysm was found with diameters around 6 centimeters, involving the left iliac external artery and to the common superficial artery. CT angio was done, and CT angio showed that there was a large pseudoaneurysm, as I told you, involving the external and common superficial artery. But also, when we did the angio, we have seen that the stent that we implanted during the Cerab technique, that they were dislodged, and back then they were in different lines, different alignment of the stents. You can see the huge pseudoaneurysm back here. So we tried to make an alignment between the two stents. First of all, we put a balloon and we tried to pull back the second stents to make just an alignment, to put the wire into the first stent and to make a alignment with third stent over there to make the amputation of the pseudoaneurysm, but this was a failed attempt. So we go back to good ampless gooseneck snare kit. So what we did, we put the snare kit retrograded from the left femoral axis. We put a coronary wire that make a couple of loops into the large pseudoaneurysm, and we try to catch with the snare from the retrograde axis, just to make a way to put another stent over there. We succeed back then. It's simple in words, but very hard to be done. That took us around 1 hour and a half, around 60 minutes of floor time. So we put a third stent that made an alignment between the first and the second stent, and this is the final result with the amputation of the pseudoaneurysm and good results, and we saved the leg in that time. So what are the conclusions? The combination of open endovascular surgery gives us the best results when applied according to the individual characteristic of the pathology. It is very important to emphasize the importance of openly discussing complications. Transparently fuels continuous improvement, allowing us to learn and improve patient care collectively. And today's success calls for open dialogue and cooperation for better results. So thank you very much for your attention.